I think we're ready to start. Good morning to all of my relations and welcome to the 2021 Minority Health Conference on Health Equity. I have the humble honor to introduce our keynote speaker, Dr. Donald Warne. He will be speaking on the impact of unresolved trauma on health equity. Dr. Warne will address the impact of unresolved trauma on the health of populations, including historical trauma, adverse childhood experiences, and toxic stress. He will also highlight the disparities that exist among American Indians, discuss the potential link between epigenetics and intergenerational trauma, and identify strategies to address health equity. Donald Warne, MD, MPH, is the Associate Dean of Diversity, Equity, and Exclusion, as well as the Director of Indians in Medicine, InMed, and the Master of Public Health Programs and Professor of Family and Community Medicine at the School of Medicine and Health Sciences at the University of North Dakota. He is a member of the Oglala Sioux tribe from Pine Ridge, South Dakota, a proud husband, father, uncle, mentor to many. It is my distinguished honor to introduce Dr. Donald Warne.
Well, thank you so much, Mona. I really appreciate being here with you and with everyone who's attending the conference. And as a side note, in my role as director of the public health program, we do have a PhD program in Indigenous health, and very happy and honored that Mona is one of our PhD students as well. So just wonderful to connect with you. So I'll go ahead and share my screen. And as was mentioned, I'm going to be discussing the impact of unresolved trauma on health equity. And I really appreciate the opening comments and recognizing that there's been, it seems to be that there's a greater degree of trauma that people are exposed to with recent events societally, but also with the pandemic and social isolation that occurs with that. So I think it's important when we think about social determinants of health, also the impact of social isolation, but also how we treat each other has a huge impact on population health. So as was mentioned, I'm Dr. Donald Warne. I'm Oglala Lakota, originally from Kyle, South Dakota, on the Pine Ridge Indian Reservation. And I serve in a number of roles at University of North Dakota School of Medicine and Health Sciences. But first and foremost, I am a community member and very closely connected to my culture and my people, and wanting to focus on ways to improve outcomes for health. So when we're talking about trauma, in medicine, I am an MD. So in medicine, when we hear the word trauma, we think of physical trauma, right? We think of a trauma center or trauma surgery where we're dealing with physical injuries. But really a trauma is an injury of many types. And there's been much more work in recent years looking at emotional and psychological trauma and wounding that can occur outside of just purely the physical arena. And this has been described in a number of ways. And some of the definitions that I like looking at things as one-time events. So even a physical accident and injury can cause emotional and psychological trauma as well, or the loss of someone close to you, the loss of a relationship, loss of a job, or a humiliating experience. These are things that can be emotionally traumatic and psychologically traumatic and have long-term impact on health behavior and even our sense of self-worth and self-esteem, and can lead to all kinds of unfortunate health consequences, even years after the event. And I think one of our bigger challenges is this ongoing and relentless stress and toxic stress that is in many of our communities. At the individual level, living in poverty is very difficult. There's a lot of stress associated with living in poverty. So we need to think of poverty as a social determinant of health, really through the lens of the trauma that it creates for many people trying to survive with limited means and limited resources. Also, we unfortunately still have domestic violence challenges, social isolation, and the pandemic. I wish we had never said social distancing. We should have said physical distancing, because in truth, during a pandemic, we need social connectedness, probably now more than ever. But when we say social distancing, it sounds like we're trying to encourage isolation. And we're seeing really good evidence in the medical literature that social isolation is a huge risk factor for poor health outcomes. Other ongoing toxic stresses can be chronic illness or chronic pain. When I was a full-time clinician many years ago, working in an Indian health service, had a lot of patients with diabetes. And quite often the diabetes causing low energy or causing neuropathy and chronic pain. I saw so much depression associated with diabetes. And the most common self-medication for depression is alcohol intake. And I really think we should consider depression as one of the complications of diabetes. I think it's largely undiagnosed and unrecognized in the clinical setting, but that really is a trauma when we think about dealing with chronic illness, chronic pain, disability, and how that has an impact on the individual level. Then, of course, there's societal types of chronic stress. Racism, unfortunately, that's still alive and well in the United States. I wish it was not, but it is. And other societal stressors, war, oppression, politics, even the growing of hate groups within our societies has a huge impact on those who are marginalized. And then finally, I think it's worth recognizing that childhood trauma in and of itself really needs to be addressed, because we see adverse childhood experiences that have a long-term impact on the health of individuals. So we've seen this, I think, really well described in the emerging psychological literature and medical literature. But I'd also put forth for Indigenous peoples, we have additional sources of traumas that are not necessarily well described, well studied, and addressed, unfortunately. So colonization itself was traumatic and is traumatic for many of our people. The whole idea of loss of land, loss of language, loss of culture. And for many of our tribal communities, that sense of loss is real, and it is impactful in terms of health and self-esteem. And I think if you're not an Indigenous person to this land, you maybe don't feel the same connectivity to the land that Indigenous people feel. And I've heard it described very well from our elders, that this land is the dust of our ancestors, but this land is also the building blocks of future generations. And from a biological and scientific perspective, it's absolutely true, that we are of the earth as human beings. All of our minerals, all of our carbon, all of our water within our body literally comes from the earth. We're literally outcroppings of Mother Earth. And when we pass on and move on to the spiritual world, our physical body gets returned to the earth. So we have that deep-rooted spiritual connectedness to land. And the loss of land is impactful, and it is a negative social determinant of health for many Indigenous peoples. We still see discrimination. We still see marginalization and exclusion. It's remarkable. I serve on a number of national boards, and I serve in a number of arenas in academic medicine and healthcare. And over 90% of the time in those settings, I'm the only Indigenous person at the table, the only one in the room. And there's been this systemic exclusion of Indigenous voices at the highest levels of health leadership and health education and academics, and that needs to end. So part of our role as academics is to open those doors, to ensure that we have more Indigenous voices and ensuring that our issues are understood, acknowledged, respected, and addressed. And then, of course, still ongoing racism. We see that certainly here in the Dakotas, and I know that's a challenge in Nebraska and the surrounding regions, but these are issues that we do have to address. So what I'd also like to do is really talk about, what populations are we talking about when we're saying Indigenous people, and what are the belief systems? And for many of us in the Northern Plains, we understand the concept of holism and the idea of the medicine wheel, and that there's connectivity among spiritual, mental, physical, and emotional components of who we are. And in truth, we can have traumas across any of those arenas. So of course we can have physical trauma. If we have physical trauma, we know that is like an injury, physical injury, where we might need to go to a trauma center. But we can also have psychological and emotional trauma. And that's what we're addressing when we look at things like adverse childhood experiences and toxic stress. But in truth, we can also have spiritual trauma. And I think that's an arena that's largely unaddressed in the current medical literature. And we probably don't fully understand the physical health impact of spiritual trauma. So this is a whole arena that we're moving forward in, at least here at University of North Dakota, trying to ensure that we address a holistic approach to trauma and understanding that health behavior has roots. And I think that lack of representation of Indigenous voices in the research community, in the academic community, and among leadership has meant that this has been ignored. It's not appropriately addressed in terms of its impact on overall health. So again, let's think about the populations that we're talking about here. And when I think about our people, the legal term for the race is American Indian and Alaska Native. And I think it's important that we're on the same page in terms of the terminology. So the race is American Indian and Alaska Native, and that's where we have self-identified racial designations on the US Census, for example. And it's the Office of Management and Budget at the federal level who determines the races and ethnicities in the United States. Why it is OMB at the federal level, I have no idea, but that's the agency that determines the races and ethnicities. And the reason we're called American Indian and Alaska Native is that not all Indigenous peoples of Alaska are American Indian. There are American Indians in Alaska. So for example, in this map, you can see the Athabascan groups in central Alaska are American Indian culturally. Athabascans are related to the Dene populations in the Northern Territories of Canada, and also closely related to Navajo and Apache groups in the southwestern part of the United States. So culturally, they are American Indian. But the Inuit in the northern part of Alaska also exists in the northern part of Siberia, northern Canada, and in Greenland. So Inuits are indigenous to Alaska, but they're not American Indian. Also, the Aleutian Islands, the island chain going out into the North Atlantic, their culture is actually much more similar to Pacific Island cultures because they are Pacific Islanders. They just happen to be in the North Pacific. So that's why we have the term American Indian and Alaska Native. I call myself American Indian because I'm not Alaska Native, even though racially I have to check the AIAN box. So really interesting terminology. Now within the population of American Indians and Alaska Natives, we also have enrolled tribal members here in the United States. So we have federally recognized tribes, and the tribes get to determine their enrollment within the tribe. So an enrolled tribal member is not a racial designation, it is a political designation, much like a resident of a state, for example. So we have self-identified American Indians and Alaska Natives, but not all self-identified American Indians and Alaska Natives are enrolled in their tribe. And therefore, not all American Indians and Alaska Natives use the Indian Health Service. So that's important when we're looking at different data to try to understand health challenges, is that the IHS data does not represent all American Indians and Alaska Natives. So I know we've also heard the term Native American, right? And I see Native American used interchangeably with American Indian, but that's actually not quite accurate or appropriate. The words Native American are actually legally defined. In the 1970s, there was the Native American Programs Act that defined Native Americans as American Indians and Alaska Natives, but also Native Hawaiians and indigenous peoples of the US territories in the Pacific. So the Chamorro indigenous peoples in Guam are Native Americans. American Samoans are Native Americans from a legal perspective. So I try to be accurate with the terminology, which is why we say American Indian. And if we're talking about those other groups as well, then that is Native American. So I've heard arguments about the terminology, and a lot of people don't like the word Indian because that actually comes from Columbus, who thought he was in India. And since he was lost at sea, we have American Indians, we have the Indian Health Service, Bureau of Indian Affairs, because Columbus thought he was in India. So I've heard people say, well, we don't like that term because it kind of honors the misrepresentation of who we are from Columbus. But even the word Native American isn't ideal because the word American comes from Amerigo Vespucci, who was another Italian explorer who named the entire continent after himself. So in truth, when we're arguing which is better, American Indian or Alaskan or Native American, we're actually arguing over which Italian explorer do we want to pay homage to. So I actually prefer the term indigenous. So indigenous peoples are the original inhabitants of various parts of the globe. So the indigenous peoples here in the Northern Plains, including Nebraska, are American Indians. So just understanding the terminology, because I'll hear people even in North Dakota saying we need to reach the American Indian and Alaska Native groups. Well, there really aren't any Alaska Natives, or very, very few in North Dakota. or when we're talking about Native Americans. So I think it's important just to have the same understanding of the terminology. But I like indigenous because it's essentially the original peoples. And we can see from this map the cultural areas of what is now the United States. And one thing that we share with Nebraska and the Dakotas is the Plains cultures and many similar languages and belief systems. And I am Lakota, part of the larger tribal group of Oyate, which is Lakota, Dakota, and Nakota. And one of our sister tribes is the Omaha. And they, of course, now are called Omaha, but originally is the Omaha, is one of our sister tribes here in the Plains. I'm very proud of my university. One of the things that we've done in recent years is to establish a land acknowledgement. And I'll just briefly read this. Today, the University of North Dakota rests on the ancestral lands of the Pembina and Red Lake bands of Ojibwe and the Dakota Oyate, presently existing as composite parts of the Red Lake, Turtle Mountain, White Earth bands, and the Dakota tribes of Minnesota and North Dakota. We acknowledge the people who resided here for generations and recognize that the spirit of the Ojibwe and Oyate people permeates this land. As a university community, we will continue to build upon our relations with the First Nations of the state of North Dakota, the Mandan, Hidatsa, and Arikara Nation, Sisseton, Wahpeton, Oyate Nation, Spirit Lake Nation, Standing Rock Sioux Tribe, and Turtle Mountain Band of Chippewa Indians. And as we're moving toward equity, I would really encourage those of you in Nebraska for your organizations, whether it's at the state level or the university level or other agencies, is really consider a land acknowledgement. I think one step toward equity is just to acknowledge the people, and acknowledging the people who are indigenous to Nebraska, I think would be a powerful thing to consider. And I know that's moved forward with some agencies and organizations within Nebraska, but wouldn't that be wonderful as a starting point toward equity to acknowledge the indigenous peoples? So I really like this map. It tells quite a story. And this shows the concentration of indigenous people by state. And you can see the majority of American Indians and Alaska Natives live in the western half of the United States. And there are now only 7 states that have at least 3% indigenous peoples. So that includes Alaska, Montana, North Dakota, South Dakota, Arizona, New Mexico, and Oklahoma. And we can see the majority of states have less than 1% of American Indian population, including Nebraska. Of course, the northern, I'd say the northeastern fourth of Nebraska has a much higher percentage of American Indian population because of the location of the larger reservations. But generally speaking, there's not a lot of indigenous people left in the US, particularly in the eastern half of the nation. And there's a reason for that. And that's because colonization started in the Northeast, and many of those tribal nations were just wiped out through warfare and through disease, the spread of disease, sometimes intentional, sometimes unintentional. And what we wind up with is tremendous loss of land. And in talking about trauma, the spiritual trauma of losing access to homeland, again, this is the dust of our ancestors. Losing that is a trauma. It is a social determinant of health. Not very well described in the literature, because I would put forth most of the writers in this space are not indigenous, and most of the publishers and editors are not indigenous. So they don't really have the lived experience and feel for what this really means from a health perspective. So where I am now is in Grand Forks, North Dakota. So that's the kind of the red circle in the upper right corner here. And my people are the Lakota, Dakota, and Nakota, and our peoples lived in what is now Nebraska, as well as the Dakotas and in what is now Canada. So the Lakota were further west, the Dakota further east, including parts of Minnesota, and the Nakota or Assiniboine were further north. So the reason this became the Dakota Territory, and the reason this is North Dakota, is that colonization came from the east. So they encountered the Dakotas first. So it became the Dakota Territory. So I always like to point out that if colonization had come from the west, this would have been the Lakota Territory, and I would be at UNL instead of UND. So we have North Lakota and South Lakota if colonization had come from the other direction. So this region is actually a sacred gathering point for my ancestors. Long before there were highways, we had the riverways for transportation. So people could take canoes along the rivers and gather in various places. And the reason this is called Grand Forks is that it is the confluence of the Red Lake River heading west and the Red River heading north. And this was a gathering point in the summertime, this whole Red River Valley. And every time I cross over the bridge and I see the Grand Forks of those two rivers, I think to myself how beautiful that must have looked, with thousands of teepees and tens of thousands of people gathered during that time frame. And as you go further north on the Red River and go into what is now Winnipeg, that's where the Red River meets the Assiniboine or Nakota River. And there's an area, if you've ever been there, it's called the Forks, where the rivers come together. Another beautiful place, another beautiful gathering point. So this entire Red River Valley was a gathering point for our peoples historically. Now, what's fascinating, Minnesota is right over here, right? Just to the east of the Red River. The vast majority of people who live in Minnesota have no idea what the word Minnesota actually means. So Minnesota actually comes from two Dakota words. Mini means water and Shota means cloudy or smoky. So in the spring and in the fall, when it appears that the clouds are rising off of the water, that is a mini Shota. So very beautiful descriptive way of talking about the land. So the land of the mini Shota, or mini Shota Makoche, is the land of the Minnesota. Now it's called Minnesota, right? So it's interesting. We have these terms that we use all the time, and we don't really know where they come from, like Omaha or North Dakota or Minnesota. So I'd also like to point out, every time you say the word Minneapolis, pat yourself on the back because you're being bilingual. Mini is water in Dakota, and polis is city in Greek. So every time you say Minneapolis, you're saying water city in Dakota Greek. So congratulations, we're all bilingual when we say Minneapolis. All right, so let's really take a deeper dive and try to understand this. And I think we can talk about traumas in very general terms across multiple populations, but I think we really need to understand the diversity of experiences across the United States. And specifically, my areas of expertise are with Indigenous populations and the historical context for why we're dealing with our challenges as we are today. The 13 colonies were just devastating to the Northeastern tribes. And there was warfare and, again, spread of disease, sometimes intentionally. So you may have heard of Amherst, Massachusetts, or Amherst College, named after Lord Jeffrey Amherst. And he was a colonial governor in Massachusetts. And he's well known in Indian country because he is the one who ordered the distribution of blankets from a smallpox hospital to the Northeastern tribes with the purpose of killing them. So our first documented case of bioterrorism is literally our own colonial government. And these are difficult things to talk about, difficult things to think about, but it's even more difficult to live through the traumas and the intergenerational impacts of this. And I talk about these things not to make anyone feel bad. That is not the point. I talk about these things because it is the truth. And I love the theme of equity in this conference. And the truth is, we will never get to equity unless we walk through truth, even when it's unpleasant, even when it's uncomfortable. But we have to walk through truth if we are ever going to get to equity. And this is part of our truth, is this history. So you can actually Google Amherst and smallpox and even find the letter that he wrote to the colonial army leadership. And this is in Jeffrey Amherst's pen, and it's in cursive and a little difficult to read. But basically what he says here is, you will do well to try to inoculate the Indians by means of blankets, as well as to try every other method that can serve to extirpate or get rid of this execrable or horrible race. Extirpate this execrable race. I should be very glad your scheme for hunting them down by dogs could take effect. So how do we address this now? Well, in our history books, we largely ignore it. And in modern day, we honor him. You know, there's a city named after him. There's colleges named after him, you know, Amherst College. But in truth, he was part of a wave of genocide that murdered many Indigenous people in the Northeast. And that's why there's so few people, Indigenous people remaining in the Northeast, because of these types of efforts. That is an intergenerational trauma and a significant loss for an entire population of people. Well, when we look at the Southeast in 1830, there was a law called the Indian Removal Act. And the Indian Removal Act was to remove the indigenous peoples from what is now the Southeast of the United States to what is now called Oklahoma. So in this process, it was also called the Trail of Tears. I'm sure many people have heard that terminology. But what happened is that some of the tribal groups were split apart. There were tribal members who refused to leave their homeland, so they stayed put. And then there were those who were removed. And that's why we have this interesting dynamic where we have Seminoles in Florida and Seminoles in Oklahoma. We have Cherokees in North Carolina, Cherokees in Oklahoma, Choctaws in Mississippi, Choctaws in Oklahoma. So you get the idea. So what's fascinating is that of the 38 federally recognized tribes in Oklahoma, only 4 of them are actually from Oklahoma. The rest of them were removed from other parts of the country, predominantly from the southeastern part of the United States, but not completely. You may or may not know the Pawnee Nation was in Nebraska for many, many years and many, many generations. And the Pawnees were relocated also to Oklahoma. So I talked about the meaning of the word Minnesota or Minnesota, the meaning of the words, North Dakota, South Dakota. Nebraska is actually an Oto Indian term, which means flat water for the Platte River going right through Nebraska. So again, we have all this terminology. Even the Omaha, our sister tribe, is now Omaha. So whenever you're saying Omaha, Nebraska, you're talking about a tribe, and then you're referencing the Platte River. I don't know how many people were aware of that, but that's what Omaha, Nebraska actually means. So you're speaking 2 words again. So Omaha, Nebraska, every time you say that, you're being bilingual in Omaha and Oto. So just an interesting part of our history that's right in front of us every day, even though we might not be aware of it. But my wife is Pawnee. She's Pawnee on her father's side and Pueblo on her mom's side. So we go to the Pawnee land now in Oklahoma frequently to visit her family, but her family's roots historically are in the state of Nebraska. And there's been some good efforts in recent years to repatriate some land back to the tribe right there in the state of Nebraska. The discovery of gold was horrible for the California tribes. And between 1849 and 1860, those tribes were just devastated by the gold rush. And there was a point in time where it was actually legal to kill American Indians to make way for westward expansion. And there was a bounty actually put on American Indians. And again, not a part of our history that's pleasant, not a part of our history that's well described in our history books, but it is a part of our truth. And again, I don't talk about these things to make anyone feel bad. That's not the point. But the point is that it is the truth. And again, I want to get to equity. I think the people who sign up for a conference like this want to get to equity. And we have to walk through truth in order to get there. Well, the bounty system was not just in California, it was also in Nebraska and in Minnesota. And we'll talk a little bit about what that means in terms of the bounty system and loss of life in the state of Minnesota pushed the Dakota people out of what is now Minnesota to North Dakota and South Dakota. So there's only 4 small Dakota tribes left in Minnesota: Upper Sioux, Lower Sioux, Shakopee, and Prairie Island. And most of the people whose ancestors originally were in Minnesota were pushed west of the Red River now into what is North Dakota and South Dakota. So this map shows the concentration of American Indians by county in the US. And again, concentrated in Alaska, Montana, North Dakota, South Dakota, Arizona, New Mexico, and Oklahoma, but certainly in parts of northern Nebraska as well. So it just gives you a feel for where our people are located now, but also that there are historical reasons and policy-based reasons for the distribution of population that we have today. So when we think about this, we have to acknowledge that there was a near genocide of American Indian people. So it's estimated that at the time of contact for Columbus, anyway, in 1492, there were probably about 20 million indigenous people in North America. And of that number, probably about 5 million in what is now the United States. So by the time we got to 1900, that number had decreased to about 200,000. So from over 5 million to 200,000. So almost a complete genocide of the indigenous Americans. Well, the good news is by 2010, there were 5.2 million self-identified American Indians and Alaska Natives on the US Census. Not necessarily 5.2 million enrolled tribal members, but 5.2 million self-identified American Indians and Alaska Natives. And we're still waiting to see what the outcomes of the 2020 census are in terms of the rebound of numbers. But what is the impact of all of that loss? What is the traumatic impact on entire populations of people who live here in the United States? So part of my research in recent years has been to look at the impact of intergenerational trauma on chronic disease disparities today. And the whole field of historical trauma really is growing, trying to understand the impact of history on health outcomes and intergenerational outcomes. So we have to acknowledge that there really was a genocide that occurred in the United States. That's a difficult term. It makes a lot of people uncomfortable to even talk about genocide, but that is what occurred. There are entire tribal groups that no longer exist because of that history. So then we see the whole idea of historical trauma. How does that get passed on from one generation to the next? In addition to some of those things I described already, there was also the boarding school experiences. And this is common across many indigenous populations. We saw residential schools in Canada, boarding schools in the US, boarding schools in Australia, where the indigenous children were taken out of their homes and placed into schools to essentially get taught another way of thinking and to lose their cultural identity. So in many ways, it was forced boarding school participation. And the time frame when the tribes were put into reservation communities, they also lost their food sovereignty. They no longer had access to traditional foods because they could no longer roam the entire regions and go where the food was. Also, the buffalo herds were just about completely wiped out. So the tribal members became dependent on federal government food programs because they lost their food sovereignty in that whole process. So what many of the families were told is either give up your children to go to boarding school or we will withhold your rations. So essentially give up your children or starve was the option that was given. And the result is we had thousands and thousands of American Indian children placed in boarding schools all over the country. And in many ways, they were exposed to all kinds of adverse childhood experiences, traumas, and abuse. And the intergenerational impact is just tremendous. Now, this is not ancient history. My mother is a survivor of boarding schools, and there are still things she doesn't want to or plan to ever talk about. She's in her 80s now. But it's a traumatic experience for many indigenous peoples worldwide and not really well understood. This also happened in Nebraska, right? You probably are familiar with the Genoa Indian School. It's now a museum, but the Genoa Indian School is where many of the Pawnees and Otos and other tribal groups were put into these schools to basically be taught how to not be Indian anymore. The idea was to kill the Indian and save the man. So this is the original building back in the 1870s. And all of those children taken away from their families, put into boarding schools, and essentially taught how to not be Indian anymore. And think about the self-esteem issues. Think about the self-identity issues. Think about the terrible things that they were told about their ancestors, the things that they were told about their family members, and forced into another way of believing in which they were taught to believe that their ancestors were heathens, their ancestors were subhuman. And I look at these pictures, these are kids at the Genoa Indian School. I don't see happy children, you know? I don't see what I see in kids today in a school picture. I see a lot of trauma. I see pain. I see anger. I see sadness. I see giving up hope. And this was a school picture. And again, this is not ancient history. You know, these are the grandmas and grandpas and great-grandmas and great-grandpas today that went through these things, and not in some foreign nation, even right in Nebraska, as well as in the Dakotas. One of the more famous Indian schools is the Carlisle Indian School in Pennsylvania. And I went there a few years ago. There was a boarding school healing conference. And what's fascinating is that next to almost all the boarding schools, they have a huge graveyard of all of these children who died while they were at boarding school. And we don't know why there was so much excess death at the boarding schools, but there was. And we know that there were outbreaks of things like tuberculosis, but that doesn't answer why there were so many children dying at boarding schools. And it also makes me wonder, what about the survivors? What does it do from an adverse childhood experiences perspective to a child who sees so many of their friends and playmates dying at an unnatural rate? What does that do to those children? And the whole idea of historical trauma is that perhaps these traumatic events can be passed from one generation to the next. This is a famous picture from the Carlisle Indian School, and many of these kids are from North Dakota, South Dakota, Nebraska, from this region, put all the way into Carlisle, Pennsylvania. And again, I look at the faces, I don't see joy. I don't see happiness. I don't see the faces of children, but I do see familiar faces. These could be my children. These could be my nieces and nephews. And it's really just remarkable the impact that this has had on Indigenous peoples right here in the plains, but worldwide, and largely ignored. I think we're finally coming to terms as a society that these are things that occurred, but it's not in our history books, is it? We ignore it. And if we're going to achieve equity, we not only have to have truth, we have to have inclusion, right? Our voices should be included. Our history should be included. And again, not to make anyone feel bad, that's not the point, but when we exclude and marginalize and isolate, we cause health disparities. And that's happening even today, just through exclusion. This is another famous picture from Carlisle, and this shows a Navajo young man upon entering school on the left, and then 3 years later at Carlisle. And this was advertised at the time as an accomplishment. This was a success story. Look, he's no longer an Indian. Isn't that great? So again, the motto was kill the Indian and save the man. What did that young man learn about being a father? What did he learn about parenting? What did he learn about cultural connectedness? And is he truly accepted in the white world? And then when he goes home, is he accepted anymore in his tribal world? We created just such terrible conflict within these individuals who had to give up who they are culturally. And that was US policy. That was the policy of the United States. And we really need to understand this and address it. Well, how does that history have an impact today? There's an emerging field of epigenetics. I'm sure many of you are familiar with this. But in epigenetics, we know that toxic stress can have an impact on DNA. It actually changes our DNA. And in animal models, they've shown that those genetic changes can pass from one generation to the next. It's really fascinating. So in mouse models, they'll take a group of mice and randomly put one group into stressful conditions. Exactly how you stress out a mouse, I'm not sure, but that's what they do. And then the other group are treated well. And then they look at impact on DNA and the genetic changes that occur in the mice that are under toxic stress can pass from one generation to the next. So I really believe that epigenetics will be the scientific platform to help us better understand intergenerational trauma and potentially intergenerational health disparities based on that toxic stress. So much of our work now is looking at epigenetics and how we might be able to link epigenetic and allostatic or inflammatory load based on boarding school experiences or other types of adversity. So that's just looking at the historical trauma and the boarding school experiences. We also unfortunately have high levels of gestational stressors. We have a lot of unplanned pregnancies. I think with unresolved trauma, a lot of our young women are addicted and quite often get pregnant And those children are at great risk for bad outcomes. And what I see our systems doing now is, well, blame the young woman or blame the kids for what happens. But that's not accurate. That's not appropriate. We should recognize that there are social structures that are leading to these types of disparities. In addition, we have toxic stress based on loss of food sovereignty. So I know you're probably familiar with WIC, the Women, Infants, and Children program. And when I was a full-time clinician, this is now 25 or 30 years ago, the WIC program on the reservation where I worked was basically a baby formula distribution center, just handing out baby formula. And the outcome of that is that the populations that had access to WIC had higher rates of formula feeding than other populations who had higher rates of breastfeeding. And that we know as a population, formula-fed babies grow up to have higher rates of type 2 diabetes than breastfed babies. So WIC, I think unintentionally, led to higher rates of formula feeding in previous decades. I will say over the last 10 to 15 years, there have been very good efforts within WIC to promote breastfeeding and not just to distribute baby formula, but damage has been done to previous generations. We're probably familiar with the commodity food program. Some of you might not be, but the FDPIR is the Food Distribution Program on Indian Reservations, so commodity foods. And this is what many of us grew up with. And now when we think about traditional foods, a lot of people think of fry bread, right? Fry bread, Indian fry bread. Well, fry bread is not traditional American Indian food. None of the tribes ever fried dough. Actually, the origin of fry bread is in the commodity food program, people doing the best they can with their commodities, with flour, shortening, lard, those types of things. So, on the left, that's a kid with a big thing of fry bread. And on the right, you can see the elder using commodity flour and commodity shortening to make fry bread. And I would put forth that the nutritional epigenetics are not well understood. When we have this type of poisonous food, I would not be surprised at all if there are epigenetic changes from that type of toxic stress. So we have to recognize this from a holistic perspective. We have spiritual and cultural trauma, we have psychological trauma, we have emotional trauma, and I would even put forth that the horrible food and loss of food sovereignty is a physical trauma to our people. And the types of foods in the commodity food program are not healthy. It's basically poison. That's improved a lot over the last decade or so. But historically, commodity foods were very unhealthy. There's a canned spam-like meat product. I'm not exactly sure what those things were, the beef and the pork. You can see the processed cheese, commodity cheese. There was a grape juice that I think was just sugar water with purple food coloring, powdered eggs, powdered milk. On the right, that large jar, you can see USDA food. This is a commodity food program. This is a large jar of corn syrup. And you may or may not be able to see it, but it says use in baby formula. Now, if you know about corn syrup, that's basically poison, right? It's an unnatural form of calories. And here our own USDA is saying, use this in your baby formula. Use it as a syrup for pancakes and French toast. That is basically pre-packaged diabetes. And this is what was distributed for generations to Indigenous people and other impoverished populations. So why do we have such high rates of diabetes? Well, there's an impact of trauma, including the trauma of commodity foods. And most people aren't even aware of this. So again, by not having inclusion, if Indigenous peoples are not at the table when we're setting the research agenda, when we're setting the policy agenda, I think that existing researchers and policymakers don't have the lived experience. We're not taught accurate history, so they're not even asking the right questions. That needs to be fixed if we are ever going to get to equity. So unfortunately, we also have higher rates of adverse childhood experiences in many of our impoverished populations, including the American Indian populations. And you're probably familiar with the ACE study, or Adverse Childhood Experiences study, but essentially the more adversity someone has during childhood, the worse their health status is as adults. So ACEs have long-lasting effects on health, including higher rates of diabetes, cancer, heart disease, higher rates of risk factors like smoking and addiction, And then impact on life potential, lower graduation rates and higher rates of unemployment and higher rates of poverty. So adverse childhood experiences have a holistic impact long-term. And what's fascinating is that there's a dose response. So the more adversity, the worse the health outcomes. And this makes sense just on a kind of an instinctive level. You know, if we see children who are going through terrible adversity, we know that those children are at risk, but we have a lot of scientific data to prove it. So this is from the CDC through the National Center on Injury Prevention. And historically, this pyramid started at adverse childhood experiences as the foundation, which then leads to things like disrupted neurological development, social, emotional, and cognitive impairment, high-risk health behaviors, early onset of disease, and early onset of death, early death. But what I really appreciate about CDC is that they've now recognized that not only are adverse childhood experiences having an impact on health, there are social determinants of adverse childhood experiences risk. So the social conditions and the local context, which is then influenced by generational embodiment and look, historical trauma. CDC is finally acknowledging historical trauma has an impact on the social conditions of a community. And those social conditions can put families at greater risk for adverse childhood experiences. So do we just blame the individual causing the adverse childhood experiences, or do we look further upstream and try to get to the root causes? Now, these are difficult things to do, but if we're going to get to equity, we have to do that difficult work. First, acknowledging that there's this problem, and then really working upstream and recognizing that we have to take a much more holistic approach. So the adversity does not end at age 18, right? We still also have adverse adulthood experiences and toxic stress. And living in communities where there's a lot of addiction, where there's a lot of violence, and communities where there's a lot of poverty, that is stressful. Living in communities where there is a lot of racism is stressful. And what a remarkable time in history we are right now, looking at violence against Black and Brown people and how that has such a huge impact on society and social determinants. I think we have the opportunity, we're on the cusp of this opportunity to really address the societal impact of racism on health outcomes. And I wish it wasn't a part of our nation, but it is. And we can either hide from it or be uncomfortable by it, or we can do something about it. And life is short, careers are short. We better work hard and for as long as we possibly can to address this, because the future generations are depending on us to face the problem head on and to do something about it. The other challenge that we see is that children who suffer from abuse eventually become parents. What have they learned about parenting? And some of the more successful programs that I have seen include community health workers and parenting skills development. So the McV programs are wonderful, maternal, infant, and early child home visitation programs. And other types of programs, there's one called Family Spirit that's through Johns Hopkins University. They partnered with a number of tribes, focusing on home visitation and parenting skills for high-risk families before they have children. This should be done pre-conception. And this should be done across entire populations. And this should be part of our policymaking. This should be part of our research agenda. This should be part of our funding investments. And we need Indigenous peoples leading this type of research in Indigenous populations. So one of the projects that I worked on, I see there's a question, have I published on this? And yes, I published on this quite a lot. And one of the studies that I was the co-principal investigator was the South Dakota Health Survey. And the South Dakota Health Survey was conducted in the mid-2010s, so 2014 to 16 in that range. And the survey included questions on basic demographics, age, sex, and race, self-reported health status, and we basically used BRFIS questions that are, so the Behavioral Risk Factor Surveillance System. We used validated questions from a multitude of sources and cut and pasted and developed the South Dakota Health Survey. This is all available online if you want to see the survey itself. We also did mental health screening, so not self-report, but actual screening, like the PHQ-2 for depression, the GAD-2 for generalized anxiety disorder, Audit C for alcohol use disorder, and we included adverse childhood experiences in the study. So the original ACE questionnaire. We sent out 17,000 surveys to random households. We oversampled tribal communities, recognizing that impoverished communities historically have less participation in surveys and other research. We wound up with over 8,200 surveys, over 500 from American Indians in the state of South Dakota. So if we look at the demographics of the South Dakota Health Survey, we can see that for the American Indian population, is over 500, for non-American Indian, over 7,000. And our sample is representative. American Indians are a younger population because our death rates are so high. We don't have a lot of elders, and our birth rates are high. So we have a lot of young people. So you can see that for ages 18 to 34 in our sample, it was about 37%, and the younger group for American Indians, about 30% for the non-American Indian. And then you can see for 65 and older, only about 6% compared to 20% for the non-American Indian population. And that is consistent with the demographics we see in the census, again, because high death rates and high birth rates means we have less elders as a percentage and many more children as a percentage. So this was our sample. In terms of other demographics or social determinants of health, all statistically significant social determinants of health, much lower rates of employment, much lower income, and much lower educational attainment, all statistically significant and all significant social determinants of health. This is looking at mental health screening. Again, not just asking the question, are you depressed, but actually screening for depression. And it's kind of a busy slide, but the light blue columns in each of those three groups is the reservation-based populations in South Dakota. And we had statistically significantly worse depression, anxiety, and post-traumatic stress in South Dakota. This would be a wonderful study to repeat in Nebraska and then to try to do something about these outcomes. So I had mentioned we did conduct the Adverse Childhood Experiences questionnaire as well. And the ACE study has 10 domains, so 3 for abuse, 2 for neglect, and 5 for household dysfunction. And look at those outcomes. For American Indians, each of those 10 adverse childhood experiences was statistically significantly worse for American Indians. Just remarkable. And not surprisingly, then the overall number of ACEs, or the ACE score, was hugely statistically significantly worse for American Indians. We have just a crisis, an epidemic of adverse childhood experiences that really needs to be addressed. And we had some respondents in the American Indian community whose ACE scores were 10, meaning they had experienced all of those domains. So for the non-American Indian population, half the population had 0 ACEs. That's wonderful. You know, we ideally see 100% with 0 ACEs. We'll probably never get there, but that would be ideal. Only 17% of the American Indian population had 0 ACEs. But when you get up to 6 or greater, these are very, very high risk categories. You see 19% compared to 4% for American Indian and non-Indian. So we know that the disparities are significant and they are real, and they're having an impact on longevity and health. And we have historical reasons for some populations being at higher risk for ACEs. So I had mentioned a holistic perspective on trauma, and let's think of this as an indigenous perspective on trauma. Do we have physical traumas? Yes, we have unfortunately high rates of violence in our communities. The psychological and emotional trauma, we have that in our communities, absolutely. We also have spiritual traumas, and that might be outside the domain of typical modern medical science. But what that tells me is that we're not wrong as Indigenous people to have spiritual trauma. Modern medical science is wrong for not seeing this and not accepting this and not doing something about it. So rather than just complaining about it, we're doing something about it. We have our own, we have a whole PhD program built around Indigenous health and integrating spiritual, cultural beliefs as well as history. and that deep-rooted connectedness to place and culture and language. So when I think about this, we also have to think about healing, right? And in the spiritual realm, prayer, the power of prayer, the power of reconnection, even reconnecting to earth is powerful. Reconnecting to culture, reconnecting to language is a part of the healing process. I've seen meditation effective for many indigenous peoples, and cognitive behavioral therapy, even culturally relevant cognitive behavioral therapy, can help with that psychological or mental trauma. We know that exercise and movement is good for healing. Even if it's emotional trauma, having physical activity is a good thing. And when I think about our ceremonies, they involve a lot of physical exertion. You know, that we don't just sit there and receive a ceremony, we participate, we're a part of it. And then in the emotional realm, those social connections are so meaningful, healthy social connections. And again, through the pandemic, when we're encouraging social distancing, I wish we had never used that term. It should have been physical distancing, maybe 6 feet apart, but promoting social connectedness, because social isolation is bad for your health. And then counseling. So we need a holistic approach. And the one thing you don't see here is pills or medications, right? I don't believe that there's a pill that's going to heal trauma. And there might be some medications that are good adjunctive therapies, but that cannot be the focus. You know, there's not going to be a magical pill. This is going to take work on behalf of the health system, and it's going to take work on behalf of those who suffer from trauma. But this is the only way to promote that holistic healing. Has this been studied? Yes, it's been studied in isolation, right? Each of those individual components is studied. Has it been studied as a holistic approach? No. And that needs to change. We need to recognize that we can't look at the lowest common denominator or the one intervention. What's the one thing we can do to fix this? Well, there isn't one thing. It's a holistic experience of trauma. So the healing needs to be holistic as well. So again, when I think about this, it's about recovery, spiritual recovery, mental recovery, physical and emotional recovery. And I love the word recovery. It's built into recovery from addiction, but also the root of the word cover, right? To cover, that sense of warmth, that sense of comfort. And this is a part of our cultures too. That we have the blankets, the healing blankets. And when we honor someone, we give them a blanket to have that warmth, that sense of security, that sense of comfort that we get from a blanket. And this is what we do now, even with our graduates. On the left, at South Dakota State University, receiving a star quilt as part of honoring for graduation and recovering from those challenges and actually making it through higher education. On the right, that's two of our graduates when I was at North Dakota State University and getting those blankets. This is at University of North Dakota, our InMed graduates, Indians into Medicine, and we honor them with the blankets and honor them for recovering and making it through these challenges and actually achieving higher levels of education to then go out into our communities and to make an impact. So we have a lot of challenges. In terms of social determinants, again, I really like the theme of this conference, focus on social determinants as well as equity. And we have terrible outcomes. So we need to address equity in a much more comprehensive way, integrating medical care, behavioral health care, public health, policy, sociology, even academics needs to be decolonized and indigenized if we're going to be effective. So I'm sure many of you have seen this image or similar images, looking at the differences between equality and equity. And I like these images a lot because it tells a great story. I think historically we've taken a one-size-fits-all approach. And on the left, you can think of the box as a package of health services or a curriculum, a medical curriculum, a public health curriculum. And we just say, well, one size fits all, right? Well, we can see that it does not. So giving everyone the same services, giving everyone the same curriculum is underserving some people. And the guy on the left didn't need it. It's serving the one in the middle pretty well, but the guy on the right is still underserved. Whereas in equity, we're not just looking at the process. I've heard so many times, well, we've never done that before. It's like, well, that's not a reason not to do it. Or I've heard people say, well, we tried it once and it didn't work. Well, that's not a reason to not try again. And we have to look at the outcomes, not just the process. And the outcome we want is equitable outcomes. And I've been showing this image for years, and someone sent me a slide that I think is just brilliant. And the question is, what is that fence doing there in the first place? And do we just need packages of services like healthcare services and educational curricula to overcome the barriers? Or should we just get rid of the barriers? And I think that's part of what we need to do as well, is let's address the systemic barriers. And that's part of what we're doing at UND. So we have our Indians into Medicine program, the InMed program. It's been around for almost 50 years. We're graduating 9 more American Indian physicians next month. We'll be at over 250 American Indian physicians out of InMed programming. We have our Indigenous Health Master of Public Health. As I had mentioned at the beginning, we have a new Indigenous Health PhD program. The first cohort is finishing their first academic year, and that includes Mona Zufante, one of our students in the PhD. And just last month, we have a new NIH-funded Indigenous Trauma and Resilience Research Center, $10.5 million grant over 5 years, renewable twice, so we could have good resources for 15 years to study the impact of trauma, but also the strengths-based focus on resilience of our communities. So we want to look at measures of stress and resilience, including epigenetics, adverse childhood experiences, but culture as a protective measure, and impact of traditional food on nutritional epigenetics. And those studies are all just now getting started. Won't go into detail, but our curriculum is methods heavy. We need better research methodologists with lived experience who can ask the right questions when it comes to research and developing new solutions. Our students are from all over the US and Canada, and we use Zoom as the format. So we're not requiring our PhD students to move to Grand Forks, North Dakota. They can be anywhere and get the PhD in Indigenous Health. And it's a postmaster's PhD. Most of our students have a Master of Public Health. One of the things I'm very proud of is our Indigenous Health Scholars. And in addition to myself, we have Dr. Siobhan Westcott, who's Athabascan from Alaska, has her MD from Harvard, MPH from UCLA. Dr. Melanie Nadu, who is Ojibwe from Turtle Mountain, has her PhD and MPH in epidemiology from University of Minnesota. Dr. Nicole Redvers, who's Dene Nukwe from the Northern Territories of Canada. She's a naturopathic physician. Her MPH is from Dartmouth. And Dr. Ursula Runningbear, who is Shichangu Lakota from Rosebud, and she's a research methodologist. And just very proud that we have Indigenous Health Scholars. And I'll end, I do want to leave time for a Q&A, but we also learn a lot from the natural world, and we learn a lot from our animal brothers and sisters, including the buffalo. And if you ever see a herd of buffalo and there's a storm, the strongest bulls stand in front of the rest of the herd and face the storm head on. And the powerful strength that's embedded within that imagery, for those of us who are fortunate enough to have the strength to stand at the head of the herd, that's our responsibility to do that. And that we have generations of people supporting us, but we also have many, many people in our communities who are depending on us to be sure to be strong for those of us, for those who are standing behind us. And I put forth that that's our charge, that is our mission, to have that fortitude to face the challenges head on and to do something about it for our people. I'll go ahead and end there.